Hi, so I'm Joshua Carritt-Baker, clinical psychologist, and I'm here with Matt Bell. We did a talk recently that quite a few people attended on Teams, which was about ADHD and diagnosing ADHD, and then looking at the sorts of things that people might or children might need in school, and also what kind of issues come up in terms of getting the right sort of provision in school. We didn't record it, and we said that we would do a quick recap of some of the key things. The first thing was that I went through some of the key diagnostic criteria, which are in the PowerPoint that I'll give you a link to, so you can read through those things yourself. I guess some of the key things that we were talking about were that, first of all, although we talk about inattention, actually for a lot of children, it's a lot more to do with issues around organisation and sort of planning their schoolwork and all of this kind of thing. Inattention isn't just sustained attention, isn't just concentration in that sense. Hyperactivity in younger children does often manifest as that kind of running around hyperactivity, but actually, as children get older, that tends to diminish, and you see a lot more general impulsivity. Can be that kind of leg tapping, fidgeting, etc., and also talkativeness comes up a lot. I think perhaps particularly in relation to girls with ADHD, where key problem is really that they find it incredibly difficult to not talk, and it's one of the things that gets them into sort of most trouble in school. It also impulsivity is also about this issue of not being able to delay the kind of thing of wanting to get an immediate reward, so not being able to delay gratification. And it can have quite a big effect on kind of social behaviour. So there's social intrusiveness, kind of along with the sort of talkativeness being part of that. And also the kind of risk taking and sort of, not thinking things through are often key parts of impulsivity. The other thing we talked about was actually the broad range of what are called the functional consequences of ADHD, and just really looking at how debilitating it is for people that have, or can be debilitating for people that have ADHD, with a significant elevated risk of all sorts of other difficulties, and obviously in particular significant elevated risk of educational failure of one sort or another. We have quite a big issue in the UK of people with ADHD ending up in prison. And this is probably related to we're not very good at identifying ADHD in the UK. We know that from an international perspective. In particular, we're not very good at treating it. In other words, you're going to say what percentage of children might it be reasonable to think need medical treatment for ADHD? Well, one way of looking at that is if you think, well, America is at the top end of giving ADHD medication, and we're pretty much at the bottom end. And countries like Germany and Holland are pretty much somewhere in the middle. And really, that's perhaps suggesting that we're not doing a very good job of identifying those children who really might benefit from ADHD medication in particular. The other thing then is really to go through in detail, and you can do this in the PowerPoint, looking at the ADHD, the specific ADHD symptoms, and thinking about, in particular this question or this issue that it's not just inattention, for example, is not just concentration. It's about all sorts of things to do with not being able to sustain schoolwork activities, and also not being able to manage time and organise their activities and so on. And that it's a much broader range of issues than people might ordinarily think that are part of the ADHD picture. We also talked a bit about the very long list of maybe something like 15 other disorders that you have to, when you're looking at ADHD, that you have to exclude for. And this includes kind of more obvious ones like oppositional defiant disorder, as well as other things that are just much less common, like bipolar disorder or a psychotic disorder. In particular, though, it's really key that the difference between ADHD and autism is teased out carefully, And certainly we see quite a lot of children who they have had an autism diagnosis, but when we meet them, the ADHD is much more prominent. And in fact, children where they got an autism diagnosis, but when we meet them, in fact, we just see ADHD. And it seems that there's been some confusion along the way about what are these symptoms of, and in fact, they've been misconstrued as being autism spectrum disorder symptoms. Actually, the two things often just co-occur, and probably most children with autism also have ADHD, and a fair few children with ADHD will have autism. ADHD is just more common than autism. It's about 5% of children have ADHD, whereas it's more like 1% or so of children have autism. And ADHD is also naturally remitting, so 5% of children, but only 2.5% of adults. So about half of children with ADHD, just sort of spontaneously recover mostly from the difficulties it's causing. And so as adults, they don't really have it. So that was a kind of an overview that I gave of the diagnostic criteria and the exclusionary criteria and the comorbidity and differential diagnosis factors, and also a little bit about kind of some of the problems that occur with diagnosis. I guess really then the key things that we were looking at were, for example, the effects that ADHD have on education and the problems that people have in terms of getting support and so on, which is where Matt was helpfully able to contribute. I don't know if you just want to start with perhaps what you thought was the key thing that people were kind of interested in terms of understanding kind of, I guess, ADHD and education and the issues that arise.
Yeah, I think initially it falls into two parts. One is the initial diagnosis of ADHD, as well as other neurodevelopmental disorders. And the second part is adjustments. We're probably not going to talk too much about adjustments tonight, but with the initial diagnoses, there are a couple of systemic issues. One is that the local authorities don't always readily accept independent diagnoses, especially around areas like ADHD, which can obviously lead to medication. That can be the local authority in terms of the SEND department, but also the CAMS department, and they like to be able to do it themselves. The other issue is the waiting times for CAMS and for assessments. And right now, it's meant to take about 6 months, but quite often it's taking about 18 months to get a diagnosis. And when we met last time, we talked about if a child is starting reception, building up the paperwork before putting in the application and then having the diagnosis and then sending it over the SEND department can take up to 3 years. So in some cases, it can take longer. And all that time, the child may not have the adjustments necessary to make that placement successful. So quite often, the school is not seeing it as their duty. They know how long it's going to take. They know it's going to take 3 years if the child just has ADHD. And sometimes, they're trying to look at what they can get for the child as quickly as possible and get them what they need. And if there's a real difficulty with inattention, impulsivity, they're probably going to be talking to the local authority anyway. And if they have a good local authority, we talked about last time, sometimes an educational psychologist comes to visit. But the educational psychologist that comes from the local authority isn't authorized to do an assessment. So they'll be making recommendations and what's called the gradual response to special education needs. And that's set out in the Code of Practice. And this system that we have in place slows it down significantly. And when it does come time to either get the diagnoses or get adjustments and SEND support put in place and then followed by an EHCP, The paperwork is very heavy, especially for SENDCos and schools, because there is a belief that ADHD can be better adjusted for than other neurodevelopmental disorders such as ASD. So when a child has ASD and they have social communication difficulties and restrictive and repetitive behaviours, that's seen as very hard to meet the needs of in mainstream schools, whereas there is a wide belief that ADHD could be met within mainstream schools and that adjustments could be in place. And that kind of tips into the next area of adjustments and what is expected of schools. And it's not in its entirety the reason why that delays the ADHD diagnosis, but it's definitely a contributing factor. And it's a risk factor with any child, especially if it's lower level, if it's not that significant. And from the SENDCos that I've talked to, where I've been advising them quite often, there's a question of whether the child could grow out of it, and whether it's a phase that they're going through, whether it's something that they can regulate over time. So there's also a limit on the amount of knowledge that schools have on ADHD.
Yeah. Okay, so I mean, just thinking or listening to you talking those issues through, I'm thinking about some of the things that people were asking about, and then we were talking about in the previous meeting. From my point of view, I suppose, the first thing is I really just don't understand quite often when I'm doing an assessment of a child with ADHD, quite how it's managed to get to the situation where it's like their problems are so evident. Really, it's not like it's a subtle set of difficulties, but almost nothing has been put in place by way of adjustments, and it's like this waiting for a diagnosis phenomenon, which is just, I mean, as far as I'm concerned, is just straightforwardly wrong in terms of the requirements under the Equality Act, for example, and where the impairments are just that obvious. The other thing, okay, you were then just talking about the growing out of it thing, and of course, this is a real issue in terms of, like I was saying before, lots of people with ADHD do grow out of it to some extent, but of course, that happens particularly at much younger ages. So a lot of children will see a reduction in problems particularly from say age 4 to age 6, maybe even on to a few years after that. But you don't know which children are going to grow out of it, and you don't know exactly when. So this thing of we'll just wait until they've grown out of it, of course, well, you could be waiting until they're 24 and they still might not have grown out of it. And so that's, whilst it's true to say that ADHD is a naturally remitting condition, it's also really problematic if you're just waiting for children to grow out of it. And that causes all sorts of problems. I guess the other thing that we talked about a little bit, but which is going to be perhaps the focus of the next talk, which is scheduled for the 23rd, is this whole issue of it relates to the question of why does it seem so difficult for very straightforward ADHD signs and symptoms to be identified as ADHD, and it's tied in with this whole thing of partly what I think can only be called parent blaming, which is kind of basically misdiagnosing or misattributing the signs and symptoms to some sort of attachment or other kind of stressor related problem, and seeing it as being a function of kind of something that's to do with the family, what's going on in the family or the parents and parenting and so on, when in general the vast majority of children who are experiencing significant difficulties with attention and significant difficulties with impulse control, the vast majority of the children are likely to have ADHD. It's just not likely to be something else. And yet, in terms of the parents that we work with, it's routine for them to have been, for their children to, have been described as having some sort of attachment problem in a non-specific way. And I think that, it's not a peculiarly kind of UK problem, but we just seem to be we seem to be kind of very much on set in this in terms of what's provided in NHS and local authority services. We just seem to be stuck in this kind of idea that actually lots of childhood problems are to do with parenting, when in lots and lots of cases there's just no evidence to support that. And that's something that we'll be, like I say, we'll be talking about in quite a bit more detail in the next talk.
I think if I just jump in there, Josh, is everything that you've just talked about there. So once the child has had an independent assessment, it's still a couple of years before they might make it to me in an SEN setting. And part of what you've said there around attachment and the question of parenting can also slow the diagnostic process down. Quite often when I get a child, if it's just ADHD on its own, is that there is a label of difficult, the difficult parent, the parent that isn't listening, it isn't supportive, and it's not accurate. And often what we find is when we dig down, and when I'm working with schools and coaching schools, or working with parents and coaching parents, is that there's been a relationship breakdown at some point where the parent is seeing things at home that they're not seeing at school, or vice versa. So ironically, when the child is exhibiting things at school, they think it's because the parent is allowing the child to stay up late at night. Are they playing computer games? What are all these things that are happening? And we hear that a lot in initial phases. And what I coach the schools to do, the SENDCos, the head teachers, is just take a more scientific look at what's actually happening, as a way of maintaining the relationship. But this is something that always comes up, is that for years and years, as a professional, that I've seen parents have to fight for the rights of their children, and it's just not automatically given. And part of it is to do with the gradual response to SEN and provision, and part of it is to do with local authorities. Perhaps politically, the split of all SEN, so that it devolved from government to local authority control, maybe wasn't the most helpful thing in diagnostics, and a lot of expertise was lost from the local authority in so doing. And it's very well published across the country, the state that local authorities are in SEN departments. But all of these things contribute to pressure on the school, and the school not having enough resources to do what they need, and for them, that relationship breakdown, which can often lead to that trope of what is the difficult parent. Although not accurate, it does happen.
Yeah, and I think that what ends up happening, of course, to some extent, is that any of us become the difficult parent, because we're trying to manage, very complicated issues with our children in terms of, what's going on at school, and then, like you say, things like not sleeping and so on and so on. And you start to become, it's like it wears you down, and you are needing, finding it very difficult to get anything like helpful support, and so on and so on. So, the situation then puts you in the position of, or I guess to some extent becoming difficult, but rightly so, because you're trying to get the support that really should be provided anyway. And actually, very often, I guess, just in terms of that point about trying to get support, very often what's really needed is also just adjustments and understanding. It's not always that something additional is needed. I mean, often, that's part of the picture, but it's so often with ADHD, what we're talking about is that it's less that's needed, not more, i.e. less time in lesson, less time that you're having to concentrate for, less time that you're having to listen for, and so on, because those are the things that are kind of required when you have ADHD. And actually, most of those things don't cost any money.
No. And I think that there were a couple of questions around that area when we last presented. One One was around how does that affect the child on a day-to-day basis, and there was a question around masking and what effect that has on the child. And quite often, if the child has strong social skills and strong empathy, strong theory of mind, that they will try and mask um, a lot of their difficulties outside of ASD, just in terms of ADHD, because they're trying to maintain what is social expectations. ASD is something different and happens in a different way, but is with ADHD that they put pressure on themselves. It can be very tiring by the time they get to the end of the day. And when you look at, and this is why I always support schools and families to start being scientific. What time of the day is the child exhibiting most difficulties? What lessons are they exhibiting most difficulties in? Where is the highest level of cognitive load? Is it at break times? Is it at lunch times? Actually, when all of the rules are kind of out of the play and it's social rules between the peers, what is happening there? And then it's about setting those very specific measurable targets that are time bonded. The time bonding is the most important part of it, because it goes on for years and years and years. And when we are looking at it as an education setting, if we're looking at it as an SEN setting, and we're looking at some type of intervention, we're really looking at 6 weeks. We're expecting, if an intervention is working, we're starting to see the effects of it within 6 weeks. And it's having those very specific, measurable, time bonded targets to start to see what's happening. And if it's not, all of those targets that don't get met, they all contribute to the diagnosis. So when the SENDCo or the school is putting together all of the information, or it's being sent to a psychologist, having those specific measurable targets that a child either reached or not reached speaks volumes of where they're currently at, what their strengths are, what their areas of need are, and is massively helpful in the diagnostics.
Yeah, I mean, that's an interesting point about the sort of time frame, because I mean, we see in terms of assessment work and providing diagnoses, I mean, we often see changes kind of from the moment that they start the assessment process, let alone from when something is correctly identified. So the thing of being able to, analyze a problem that's perhaps been going on for a long time, to develop a proper understanding of it, and to start to see what kind of things help, that in itself can make a huge difference. And then the moment you start implementing things like reducing the overall level of stress on a child with ADHD, you see very quick results. Yeah, it's sort of, or you can see very quick results. These things can start to shift very quickly. Whereas if you don't take those things into account, so if you don't reduce the overall level of stress, but you just do lots of other things, none of those things might work at all. And you can go on forever providing other sorts of input and asking them, or talking to them about why did that happen or why did this happen, and you'll never reach an answer, because the real answer is, well, because my impulse control systems don't work properly and therefore I lashed out, that kind of thing. And actually I need to be in a situation where they're not being stressed so much. And that's the real answer. And of course, no child is ever going to say that in terms of why they did something wrong, or whatever happened. I think probably I'm going to. We had a number of questions that people posed in the chat, and we've answered some of them, but there's quite a long list. And what I was thinking we might do is that we could work through that list individually, and where we've got something relevant to say, just to record ourselves giving our answer to the question. I guess maybe before we do that, is there anything else that's kind of came up from the conversations that we were having before that we perhaps haven't covered? Yeah.
I think there were a lot of questions, but I think they're going to be covered next time. The biggest area of difficulty, I think, is when a diagnosis does happen, why don't suddenly everybody put everything in place? And I think that's one of the biggest area of frustrations for families, for professionals. But it's an hour on its own, that conversation at least.
Okay. So this is a quick whiz through the questions that were asked. Actually ended up in no particular order. But can ADHD and gender diversity go hand in hand in some cases? And what might the link be? Well, yeah, neurodevelopmental issues and gender identity and gender diversity definitely go hand in hand. So we know that, for example, an awful lot of people that were born as girls and who are experiencing gender identity issues will also have usually autism type neurodevelopmental problems, but there's a very close link between neurodevelopment and our experience of our own gender. Can I talk a bit about how girls present differently to boys and the mental health fallout of ADHD in teen girls? Yeah, I mean, broadly speaking, it seems that girls just perhaps don't display as much of the kind of obvious impulsivity, hyperactivity, and that when they do, there's also the issue of how that's kind of perceived and interpreted by people. And it seems like, I think, as with other things, the girls get a bit of a double whammy then, which is that this kind of thing of it just not really being understood in terms of what might be going on for a girl, and they're perhaps seen as having some emotional problem and so on, that perhaps with boys would just be more straightforwardly understood as ADHD. Also, I think a bit like with autism, perhaps girls are just more able to kind of muddle through, masking their difficulties and so on. I certainly just, I've seen enough teenage girls in particular with significant mental health problems because of their ADHD, and it's this long-term thing of not being able to attend to things in school and not being able to manage their kind of relationships in the way that they want. And it's not, they don't necessarily have evident autism spectrum problems. It's just the way that the autism, the ADHD is impacting on their social relationships. There was a question about kind of links between ADHD and addictions. Yeah, I mean, unfortunately, there just is a very strong connection between ADHD and various forms of addictions. So they were referring to smoking, cannabis, alcohol, which, yeah, that is certainly the case. There's also a question about being addicted to the internet. I mean, I guess ADHD is very much tied up with how our reward systems work. That was one of the things that I referred to earlier in looking at the kind of diagnostic information. And also that, and this relates to another question someone asked, it's this whole thing of how does your brain interact with this activity that you're doing, and you end up with hyperfocus. So when you're particularly interested in something, you then click into it and you end up being able to do it for long periods of time, whereas if you're not interested in something, your attention level goes right down. And whilst that's true for everyone to some extent, with ADHD it's just massively exaggerated. So you get the hyperfocus and then the complete inattention to things that you're not interested in. Someone then asked how easy it is to distinguish inattention from things like sensory processing issues. Yeah, I mean, obviously they can all look quite similar in some respects, and I guess the thing of distractibility. So if you are sensory hypersensitive, you may well be very distractible because of auditory issues, and that's going to be essentially the same as distractibility as you'd see it in ADHD. There's not necessarily a complete distinction, and in the end, the most important thing is distractibility a problem, and if it is, what's going to be done about it, rather than what's the precise way in which we understand the nature of this distractibility. And then other questions are things like relationship with sleep disorders. Yes, unfortunately, ADHD and sleep disorders just go hand in hand. It's ADHD is all tied up with kind of the regulation of bodily systems throughout the day, and whether you're going through the normal periods of wakefulness and sleep and so on. It's in many ways ADHD is a disorder of bodily regulation in that regard. And certainly there's information about that in the NICE guidelines, and there's specific information about, for example, melatonin use and so on. And someone asked about the link with epilepsy. Yeah, well, I mean, epilepsy is just more common with if you have neurodevelopmental disorders and vice versa, I mean they are a kind of comorbid set of things because they're all to do with brain development. So yeah, you're more likely to have a neurodevelopmental condition if you've got epilepsy. There were questions about medication. Do you have to go through CAMS for medication? Well, you have to see a prescribing medic. It won't be your GP. Whether that's through CAMS or a private practitioner, that doesn't make too much difference. But yes, you need to see a prescribing medic in order to obtain, and it's generally a child psychiatrist. There may be other medics who might also prescribe ADHD medications. Just in terms of ADHD medication, the first line ones are the stimulant type ones like Ritalin, and broadly speaking, the way that we understand how they work is that in our brain we have these excitatory and inhibitory systems, and that these are like the engine and the brake systems, and that when you have ADHD, your engine system is too strong for the brake system, and the stimulant medication stimulates the brake system to bring things back into kilter. And a last question that someone asked was whether there might be class action to sue the government for lack of action in this area. I don't know if there is at the moment, but you kind of think that it's the sort of thing that could happen, because there is not just probably a generation, but multiple generations now of people who have been kind of failed or let down in terms of understanding their ADHD. And given that it's a common disorder, so 5% of children, 2.5% of adults, and that the implications of failing to recognise it are so great in terms of educational failure and lifelong problems potentially, it is the sort of thing that may well be looked at in terms of a class action. Certainly sort of thing where, if you think about the history of legal cases in relation to dyslexia and educational negligence, that I think ADHD is really the other huge area of kind of failure in terms of kind of diagnosis, and then the providing the right sort of education for people with ADHD.